Thank you. Thank you for uh, giving me this opportunity because we need to tackle women's issues right throughout their life cycle. So the current trend in medicine is to tackle issues on the basis of life cycle, especially with the point of view of a general practitioner or generalist. That aspect is more important. We know that Sri Lanka is aging, and out of that change in aging structure over these years, it is predicted to get even worse. By 2025, females will be more, and 2050, it's even worse. And another 50 years' time, it is going to be even a dramatic change, and more females will be living. And they live longer. As of today, women tend to live 6 years more than males. Males life expectancy at birth is 72 years. Women it's 78.8, almost 7 years more. And majority of women are living beyond 65, and most of them will be living alone. And most of the time, if they are not employed, will be dependent on social network for their support. And this hammers the same point. You can see from roughly from about age of 50, females are increasing in number in our population, and 60 and above it's even worse. So I'm not going to tackle the elderly crowd, it's the middle age. And since they are living longer and still being productive and active, we need to be looking at their issues more closely. The problem with my topic today is that it is very difficult to define. Middle age, midlife, difficult. So I had to go with the dictionary definition, which is roughly the period of life between from about 40 or 45 years to 65 years. Various authors, various experts classify it as differently, but I preferred the midlife. Because there had been some literature in mainly psychological and well-being literature, which was initiated by this guy from Canada called Elliot Sharks, saying that there's a crisis in midlife. Actually, he described it with regard to males, and he analyzed artists and composers, and he noticed that their creativity reduced, and they had an issue with creativity. And then some people extrapolated it to everybody, and it went as a viral thing in all the journals and other media. But now we know that it is probably not uh, as important as it was described. So there may be an element of truth in the crisis, but most of those things can be explained by, especially in women, by going through the menopause and other social, psychological aspects which change at that particular time. So during our lifespan, we go through several phases. So those issues might be uh, posing off as issues of midlife. And anyway, it is not considered a diagnosis. We need to change our approach to midlife women, mainly because in our country especially, we are focusing our attention mainly to maternity, pediatrics, and their health aspects rather than other life experiences of female. And basically after childbirth, female are not of interest to our health service, though they contribute to the majority of the population. The attention paid to them in our health service is minimal. And when we train also, we don't put much emphasis on training or equipping our doctors to handle women of middle age and beyond and elderly. So these things need to be changed. And our care model is generally more or less hospital based, hospital focused practice. We don't give any focus to community-based, general practitioner-based model of care, which is common in other countries, and majority of population is handled in that basis in more efficient way. Probably with the current financial constraints, probably we may have to find this more cost-effective way of handling healthcare, especially women's healthcare. So, going back to the issues which are common in midlife women, it's the list is long. Some of them are like this: abdominal vaginal bleeding, cancers, issues of contraception, and menopausal, perimenopausal symptoms, and mood, sleep disturbances, osteoporosis, pelvic pain, and other symptoms. Sorry, there has been some formatting issue with my version of PowerPoint and the version here. And some premenstrual symptoms, sexual dysfunctions, problems with libido, incontinence, urogenital syndrome of menopause, dyspareunia, which probably may be contributed by that, changes of weight, commonly around the time of menopause, issues of body image and concerns, and abnormal uterine bleeding and postmenopausal bleeding. Those are the common issues. And then we have some psychological issues like bereavement of their parents, partners, empty nest when children are leaving homes, and mostly they feel spent or worthless. And some of them may have issues of unfulfilled dreams which they have planned in their early adulthood or in childhood. Relationship issues in the family, especially with the partner as well as with the children, older children and elderly parents. So it is not a wonder when that women in midlife are facing so many challenges. So as doctors, we need to be ready. So what can we do? First thing is we need to understand that there are issues facing women. Whoever who comes to you in the general practice, understand that they are going through quite a lot of changes in their life. Express empathy. So you try to understand their issues in their field. And then we need to develop our interpersonal skills, how to gently break their issues and ask about them, and ability to sensitively handle them. We need to develop the communication, interpersonal skills of doctors need to be improved. And then we need to update our knowledge and go through the latest research outputs to see and provide them with evidence-based information and care. And then we need to develop screening and preventive skills, probably a bit of psychological and social skills of handling those issues, and then developing a supporting relationship with the patients. And sometimes you may have to act as a mentor or a guide to patient. And wherever you come across a woman in their whatever stage, especially in midlife, you need to try and do this opportunistic health education. Maybe they are coming with their child or elderly mother, but still pay some attention. If you are a general practitioner, you should really look at the whole family and then at least guide them. See if they are obese, warn them. If they are having other issues, treat them and then at least screen them. And then develop a set of resources around your practice, around your area. You need to develop a set of resources, support groups, help groups, focal points, say certain set of physicians or consultants who are looking after people. You need to develop and then probably refer your patients and then develop a continuing relationship with them for care. And most importantly, you need to prepare your patients to face their life beyond middle age, 65 and more above. That is your main job, because if you prepare them well, they will face their middle age well and will not be a burden and will not be a hindrance to their society. So we'll go back to our main topics and we'll first see what we need to do as with regard to screening and preventing certain issues in midlife. There are two approaches. One is to do a routine checkup, which is practiced in other countries. We don't have a system like that. So it is mostly when they come with symptoms related to midlife issues, menopausal issues, or opportunistic health screening whenever they come, say, for blood pressure treatment, you go through other symptoms and see other systems and see. So routine screening is generally recommended in most of the countries, especially in US and other Western countries, whenever a general practitioner comes across a ask about general well-being, lifestyle, their mobility, and their day-to-day activities. Assess whether there are any risk factors. And you need to practice the gently breaking of issues about sexuality. Ask their sexual behaviors, any problems with their sexual function, whether there have been any issues with infections, and then remember that they might have issues with the loss of libido, especially around menopause or post perimenopause, and issues of dyspareunia with urogenital atrophy due to lack of estrogens, and sometimes they might take a little longer to orgasm. So these issues might need to be addressed, and you may probably have to have tact in handling them. And sometimes the male partner may already be receiving treatment from our colleagues in urology with drugs like sildenafil. So the women sometimes may feel that they are inadequate to handle the demand. So problems. And some in occasional cases, you may have to treat them with vaginal local estrogens, even if they are not suitable for HRT. Then general activities, physical activities, dietary adequacy of nutrients, calcium intake, vitamin D levels, you may have to consider, and in your history you need to take these things into account. And then social, psychological and social issues like neglect, abuse, intimate partner violence, lifestyles and related to stress related to them, depression and sleep disorders. Some of them may be related to menopausal symptoms, which I'm going to tackle in future, but some of them may not. And relationship issues, economic issues, some of them may, especially in urban areas, semi-urban areas, they may be drug dependent. It's not uncommon. So we need to think about them and handle. And then you do your medical risk factor evaluation and then treat them. List is extensive, so I will skip this. And then assess other health risk factors, check cardiovascular risk factors, diabetes and other metabolic risk factors, and see whether they are facing any occupational hazards, especially when they are towards the latter part of their midlife, close to 60s or 65. Try and see whether you can assess their risk for fractures, prevent any falls, change their recreational hazards that they are facing, see if they are driving, whether they are safe to drive, all that to be checked. And then other health risk factors like chemical and radiation exposures, suicidal risk, again may have to be checked. And you do your routine assessment, especially putting more emphasis on breast and abdominal and pelvic assessment. But pelvic examination probably may not be necessary unless they have symptoms related to them. So I will tackle two common issues, which is menopause and urogenital symptoms, and others, though they are important, the time does not permit me to go through in detail. We'll try and see whether we can address them while tackling menopause. In general, the menopause is defined as absence of 12 menstruation for more than 12 months without other explanations. And some of them, females might welcome them, the change of life, but in most of the countries, it is considered in a negative way. So, as a remedy in 1960s, late 60s, HRT was proposed. So there was a huge uptake of HRT in Western countries in the late 60s and early 70s, and then at that time it was mainly unopposed estrogen based hormone replacement, which resulted in some cases of endometrial cancers, and then combined HRT was introduced. So it was all pro HRT until about 2002, when this Women's Health Initiative results came and put a break to that practice. and the practice of HRT declined by 80%. Basically, some companies withdrew their products from certain markets like ours because they could not sustain the volumes. Uh, some basic facts regarding menopause: it is a thing which happens between 51 to 50 years of age. Uh, about 1% will be menopause by around age of 80, 40. By 45, about 5% will be menopause. So before 40, if somebody goes through menopause, we term it as premature menopause, and in those cases, we treat them with hormone replacement. Majority will be menopausal by around 60 years. So with simple numbers, you can see that 30 to 40% of females' life will be spent post-menopause. And it was not a problem in the 1900s because average lifespan is also around 48 years. So by the time they reach menopause, they are going to die. They were about to die, but now it's not the case. Symptoms and signs are numerous. If you go through a textbook, you will see quite a lot of things which are attributed. But when you analyze them, some of these symptoms are really not directly related to lack of estrogen, and they may be due to other coexisting psychosocial issues which are happening. The two main studies which clarified this were Melbourne Midlife Women Study and Penn Ovarian Staging Study. And based on these studies, these symptoms are the things which are probably attributable to loss of estrogen. Vasomotor symptoms like hot flashes and night sweats, and sleep disruption and vaginal dryness. So these are the things which we might have to uh, control by giving estrogen, not everything else. So treatment for cardiovascular protection, bone protection, cancer protection are all out. And some other symptoms which are coexisting may be due to changes which are there in age. Because the picture of menopausal symptoms are complicated by psychosocial issues which I mentioned earlier, like changing their work, children leaving home, and burden of taking care of in-laws or their own parents. All these things will adapt to the symptomatology of the patient, and especially if they have a history of depression and other mood disturbances, they are likely of having menopausal symptoms have shown to be increased. So it's the normal response of a woman to life stresses. So vasomotor symptoms are the commonest thing which we need to tackle, and usually it is defined as being accompanied with sweating and stopping the activity of woman. Majority, about 50% of them, will say that they cannot continue with their work due to sweating. We don't have any clear idea about mechanism, but some people say the thermoregulatory center is estrogen dependent, and when you're treating with estrogen, that thermoregulatory functions will become normal, and some neurokinins are implied in the mechanism, and most of them have accompanying loss of sleep. Whether hot flashes predispose to sleep deprivation or sleep deprivation is a coexisting thing, we are not really sure. Then we have urogenital syndrome of menopause, which is vaginal dryness and dyspareunia and burning symptoms. And usually they include recurrent UTIs as well. And some of them might have prolapse and incontinences. So whenever your patient has recurrent UTIs, if they are in the perimenopausal or in midlife, think about lack of estrogen. They do not need to go, not to have a full menopausal diagnosis. Some of them may have loss of estrogen or estrogen deficiency while they are still having occasional menstrual bleeds. So symptoms might come earlier. So consider this in anybody above 40 who is having recurrent UTI. Some of them can be treated with topical estrogen therapy, and whenever you have indication for systemic hormone replacement, and may be relieved by selective estrogen receptor agonists like raloxifene. Decreased libido is a main issue. It is due to multiple factors. It's not just related to lack of estrogen. Maybe dyspareunia due to vaginal dryness may be contributing, but other symptoms are there. So you need to develop this habit of asking this question, that most women tend to have issues with libido in menopausal age. So are you having same issues? That will probably open their mind to discuss the issue with you. So as a general practitioner, it is always necessary for you to break the ice so that they are happy to discuss their issues. There are not much pharmacological agents, so testosterone implants is generally prescribed, but you have to be very careful because it might increase their metabolic risk factors as when you are giving higher doses, and you need to really be selective. These flibanserin and other melanocorticoid agonists, they have been approved in America, but I don't know whether we have any access to them. Then mood swings, cognitive decline, depression, they are linked with menopause, but most of the time women have had issues with their mood or psychological stability, and when they go through menopause, things are worse. They tend to get worse, and then sleep deprivation may aggravate these symptoms. So whenever you are handling a patient, inquire about their sleep, whether it is adequate or not, and if not, probably you may have to intervene to restore a good sleeping pattern. Then achiness. Most of menopausal women complain of generalized body aches and pains. So they end up cluttering medical clinics or gynecological clinics with these symptoms or the OPDs. As a general rule, you need to exclude any collagen vascular disease, probably by screening, and then remember that it is not mostly related to this bone loss or osteoporosis. It is most frequently and commonly it will respond to some sort of HRT. Weight gain is another issue around menopause, and it is common to menopause due to a change in the fat distribution, and women in menopause tend to gain fat more around the abdominal area. We really do not have any proper etiology with regard to how it happens, but probably less physical activity and loss of muscle mass may be contributing. In general, about 2.5 to 4 kilogram weight gain had been noted during menopausal transition in women. So you need to be prepared to handle that. Skin and hair changes common, and always exclude any thyroid dysfunction before attributing it to loss of estrogen. And some will be demanding HRT purely because of hair loss. So you need to notice. Then other issues like osteoporosis, you may be familiar with the in their fracture risk. Depending on their risk profile, actually, you may have to do a DEXA scan a bit earlier. And usually when we start on HRT, we do a baseline assessment prior to starting HRT using this, and this is online available, specifically customized to Sri Lanka, so it's freely accessible. And there was app, but probably it is no longer available on the app stores. So you can use the web version, assess that, and then see, depending on the risk factor, you might have to refer the patient to the endocrine team for handling. Other important issues like cardiovascular risk assessment, I'm not going to into detail, but you may be familiar that you need to screen and then probably take actions and then change their smoking habits and screen for diabetes and other issues. Especially if they have an obstetric history of severe preeclampsia, that increases their cardiovascular risk profile in the future. So please note that and take action. And then calcium and vitamin D assessment I have mentioned earlier. You need to take generally recommended daily dose intake is about 1200 of calcium, and vitamin D at least 800 international units. So if the history is showing that it is not adequate, probably either you should go for assessing the vitamin D levels, which is expensive, or you should start them on a regular vitamin D treatment and calcium. Changing their lifestyle probably might help to relieve some of the symptoms, like if they are in a cold weather and are having issues with vasomotor symptoms, then asking them to wear layered dressings might help with hot rashes. And keep the bedroom cool, especially around the first 4 hours of their sleep might help. Not right throughout the night, so at least 4 hours, especially with regard to power cuts. Probably ensure that when you are going to sleep, at least for next 4 hours, it is cool. Cooling pillows might help. And then if they are soaking at night with sweat, then probably I advise them to use another set of night clothes. Keep them handy. And there are various triggers like hot beverages, spicy food, and even wine might trigger hot flashes, so ask them to avoid. And in other countries, alcohol has been linked as a treatment or touted as a treatment, and evidence is that it actually worsens the symptoms. Herbal products are marketed, a lot of them are available, but not much of evidence to say that they are good for relieving vasomotor symptoms, except soya, probably because soya has isoflavones which are of help. Moderate effect is there, and some of these hormone therapies or estrogen extracts are actually extracted from soya, so can be used, but the problem is whether they are having any influence on breast cancer incidence is not very clear. So you have to be very careful, especially in people who are at higher risk of having breast cancers when you are prescribing uh, soya based products for treatment. So all isoflavones belong to that category. Then we have SSRIs and SNRIs. Both are helpful in relieving symptoms. Paroxetine, gabapentin, and they are all being used. And actually, FDA has licensed paroxetine as a treatment for hot flashes. Ginseng and other isoflavones treatments you can use. Probably there is a huge placebo effect in them, so it might work. Then we have HRT for these symptoms. It is the most effective treatment for vasomotor symptoms still and for genitourinary symptoms of menopause. There is some effect on preventing bone loss and fractures, but we are not really treating them for that. There are better treatments, and you should actually refer your patient if the fracture is high. Rather than thinking of recommending HRT, they should go to a proper metabolic assessment and treatment by endocrine team. And the risk of hormone therapies like breast cancer incidence and how long you should give the dosage are very controversial. It is actually an individualized risk assessment based treatment. You should go through the patient's history, and after assessing only you should decide. So in most cases, we would advise you to refer the patient to a specialist service to get that advice and assessment. After that, they might start, and then you can monitor their progress and response to treatment. And always you need to reassess them regularly. And prior to starting, you need to assess their risk, like lipid profiles, fasting blood sugars, and if necessary, mammograms and other screening for their metabolic risk assessment and cardiovascular risk assessment before starting treatment. And after that, you need to follow their response and then readjust the hormones. Great. Yeah. Um, Sorry about this. So the treatment, when you are starting HRT, the first thing you need to remember is whether the woman has a intact uterus or not. And then if the uterus is not there after hysterectomy, it is much easier. You just need to start them on estrogen only treatment. And the common preparations which we have in this country are conjugate uh, conjugated the estrogen, equine estrogen, or Premarin 0.625 milligram, or estrogen only preparations with ethinyl estradiol preparations, either one, and ethinyl estradiol valerian preparations. All are were available but no longer available due to these financial issues and of the country. So you start them in the lowest dose and then after about 2 or 3 months reassess their response. People with uterus, you need to consider them starting them on a combined estrogen progesterone therapy. If they are within 2 years from menopause, you can start them on combined estrogen progesterone treatment, and then usually start them on a low dose of estrogen containing preparation. There are various preparations which are available at the moment. Femastan or is the brand which has 1 milligram and 2 milligram of ethinyl estradiol with dydrogesterone 10 milligrams with the same pill. And they can be given, it comes as a 28-day pill pack. So you give them, and the last half of the cycle for 14 days, progesterone is added. So they will have a cyclical type of bleeding with uh, so they people who are going on combined treatment, you need to warn them that they will get regular like periods. And after 2 years from menopause, usually we change them to continuous combined treatment, which has estrogen and progesterone right throughout the cycle in the same concentration. We don't put them on continuous combined treatment immediately after menopause because occasionally they might have ovulation, and that high estrogen might have cause breakthrough bleeding, and it will mess up their impression about HRT. So, and they might get frightened. So, because of that, we usually put them on continuous combined therapy after 2 years from menopause. And how long you should go is actually another question I will address later. So these are the preparations which we have. For sequential therapy or the cyclical therapy, you have these preparations and they get monthly bleed. In continuous combined treatment, we have Cryofem and Femostan. Continuous combined treatment, generally in the pack you will see the name word continuous. It indicates that it is given continuously with the same preparation. Cryofem and Femostan, but I think Cryofem is no longer available. Then we have another drug called gonadotropin, which has estrogen and progesterone both actions. Tibolone is the generic name. It's called Livian. Useful, but the problem is it's like again another estrogen preparation. So there are risk on breast, and DVT is almost like estrogen containing preparation. So initially it was considered a wonder drug, and almost everybody who was having risk factors or estrogen only treatment were put on this, but then later they were shown to have similar risk profile. And then we have unopposed estrogen preparations. Premarin comes as creams as well as tablets. Usual strength is 0.6 to 5 milligram. Tablets and cream. Cream is very useful for urogenital symptoms, incontinence, recurrent UTIs. Most postmenopausal women respond very well, and after establishing that they are not having other causes for the UTI, you might start them on local therapy. Even after breast cancer surgery for malignancy, still it is safe because the level absorbed is very low. So it is something you should consider. Proginova is another estrogen preparation, estradiol valerate from soya origin. It comes as 1 and 2 milligram tablet of 28 day max. And it is on these two are indicated when you alone when you are not having a uterus. They can be used if even when they are having uterus if the patient requests, but you need to make sure that the endometrium is kept quiet by inserting a progesterone containing intrauterine device or levonorgestrel containing intrauterine device, LNDIUS or Mirena, and that will keep the endometrium thin, and you can use tablet to provide HRT. So that combined can be used. And especially if they have perimenopausal symptoms prior to the normal menopausal age, in the absence of other contraindication, you might use a low dose OCP as a substitute for lack of HRT preparations, especially when they have intact uterus. When you don't have any other choice, you can use estrogen progesterone containing pill at a lower dose with lower doses of estrogens. The normal Mituri has 35 micrograms. You can use 20 or 25 microgram estrogen containing pills which are in the market. Familon or Dronis, they are available. You can use it. Then HRT related cancer risks. I have mentioned that vaginal preparations are safe. Most systemic treatment with HRT is systemic therapy with breast cancer survivors is generally not indicated. Most of the time, the oncologists are not happy. HRT increases the odds of having breast cancer by about 1.21, a slight increase compared to the normal age-related risk or the population-based risk. And you need to discuss if you are starting on HRT about that risk. It has been shown that ovarian cancer risk is also increased, but the moment you stop HRT, that risk reduces to the background risk. We don't have any idea how ovarian cancer risk is increased with HRT. Endometrial cancer risk is increased with unopposed estrogen mainly. When you have progestogens, that risk is not increased. And especially with regard to endometrial protection, you can use levonorgestrel IUCD to counteract that risk completely to zero. So it is safe. Other cancer survivors, hematological cancers or the other solid cancers, most of them do not express estrogen receptors and can be treated safely with HRT. So in case of a doubt, you need to discuss that with the gynecology team so that they can give you a better idea. How long? There's no decision, but generally for starting, there is supposed to be a safe therapeutic window. You need to generally consider starting HRT within 2 years from the menopause, around 2 years. Before menopause, you can start, But after 2 years from menopause, generally we don't. The risks are slightly higher based on WHI Women's Health Study. It is not recommended because the risks are more with starting HRT. But how long you can continue, nobody is sure. The consensus is that it is a individualized decision after discussion with the patient. Most of the patients generally discontinue treatment within 3 to 5 years from starting HRT. I'll briefly touch on urogenital atrophy because that is the other thing which you might have commonly, and it is when they are without HRT, usually it comes as a slight itching and recurrent UTI, and there may be a discharge. But if the patient is on HRT, they might come with candidiasis as well. Generally, in a postmenopausal woman, if you see candidiasis, it is usually due to diabetes, uncontrolled diabetes. Otherwise, there's no reason why candida is there, should be there in the vagina. And if the woman is around 65 or close to 70, always consider biopsy if it is suspicious, because vulval cancer may be there. It will be generally shown as a very narrow introitus with minimal moisture, and urethral orifice will be widely open, and sometimes mucosal prolapse also may be there, which again will respond to local estrogen therapy. This is the reason why these things happen in due to lack of estrogen. Commonly it comes as dryness, burning sensation, decreased lubrication during sexual activity, or they might have fissures on the vulva, and they may feel vaginal bulging, and frequency, pain, bleeding, and incontinence is also complained of. Treatment is usually with anti-infective treatments, HRT, and sometimes we treat them with isoflavone treatments when you don't have to use systemic HRT. Prolapses, not uncommon, but usually you need to send them across to a gynecology unit for treatment. And even after treatment, they might again come with small prolapses. Occasionally, when the woman is very old, we might resort to this, but it is unlikely in the midlife age group which we are discussing. Again, due to menopausal issues, they might complain of bladder control problems. So they will be living around the toilet most of the time if you inquire carefully. And after complicated childbirth, they might be even having fistula. Even after treatment for endometrial or ovarian cancer, they might have a fistula. So check carefully in the history and examination to make sure that they are not having any problem. Incontinence may be due to lack of estrogen, but due to lack of tissue strength, the bladder neck may prolapse below the pelvic diaphragm and will lead to leakages, and it's not uncommon, and it's generally seen in about 15 to 30% of women when they are above 60 years of age. And long term, almost about 50 to 80% of women will face some sort of incontinence in their elderly life after 65. There are other issues like elderly abuse, neglect, and lack of proper health care when they are, especially when they have urinary symptoms. So you need to, if they come across for some other reason, always check these issues with the patient and as well as the family. Other conditions like chronic constipation may be there, or neurological disability, chronic diabetes related neuropathy, all may contribute to incontinence. So you need to go through the history and see and do a proper evaluation. And sometimes when they have, especially when they have incontinence, we advise them to reduce their caffeine intake and reduce the fluid intake at night from about 8 o'clock at night We ask them to reduce and then compensate that during the daytime. That will help them to avoid nocturia as well as unnecessary leakages while going to toilet due to urgency. And always check their medical history and the drugs which they are on. So most of the women passing the midlife will be on a whole heap of drugs. So whenever you see them, avoid polypharmacy, try and minimize cross reaction. Always check the BNF for interactions which may be the complaint the patient has after starting on treatment. So take this as a clue to remind yourself cells to check and reduce unnecessary usage. And sometimes with people who are having urogenital symptoms, you may have to inquire into their mobility and quality of life. There are questionnaires available on the website you can use to identify incontinence related issues. And always check whether there are carers available as well. So as a woman prepares their life beyond midlife, you need to go through them. The investigations like urodynamics and general treatment, sometimes skipping them, they are usually in the area of specialist services. Other preventive measures you need to ensure in women in their midlife and especially late midlife are cardiovascular problems, cancer screenings, and falls prevention, advice about diet and exercises, and especially with regard to incontinence, other availability of other incontinence support devices like catheterization, incontinence pads, and even vaginal pessaries. And though we say that towards the end life is going to be very unhappy, the research is not always saying the same story. They say that from some women at least, from midlife onward, they are showing increased satisfaction. Maybe people who have achieved their goals which they have set probably are enjoying after their children are grown and leaving their homes, they may be feeling better. So statistically this is the curve. So it is a U-shaped curve. So probably around midlife it is at the lowest. Towards the latter part they may be more happy. And always keep them active. And you need to encourage your patients when they are midlife and going beyond, always to be active, use their brain so that they avoid the curse of old age like dementia and physical disability by keeping them active. So always encourage them to be active physically, which will help them to keep their brains healthy. If there are questions, I can help try and answer. Any other? There are a couple of related articles which I have gathered, including this presentation. You can download them from them if you can scan the QR code.